Welcome to the Point of Care Ultrasound curriculum for the Internal Medicine Residency Program. This presentation is going to focus on lung ultrasonography. By the end of this presentation, you should understand the recommendations on lung ultrasonography from the Society for Critical Care Medicine, be familiar with lung anatomy, understand how to perform the lung exam, understand normal lung parenchyma, evaluate pneumothorax using B mode and M mode, evaluate interstitial syndrome, understand the signs of pneumonia on ultrasound, evaluate pleural effusions, have an understanding of the Blue protocol, and have a basic understanding of potential implications using lung ultrasound for weaning from mechanical ventilation. The Society for Critical Care Medicine makes a few recommendations on the use of lung ultrasonography in respiratory failure. For pneumothorax, they recommend that ultrasound should be used to complement or replace conventional chest radiography to diagnose a pneumothorax, depending on the clinical setting and need for rapid results. For pleural effusion, they recommend that ultrasound should be used to complement physical examination and conventional chest radiography to diagnose and localize a pleural effusion. For interstitial and parenchymal lung pathology, they suggest that a systematic approach incorporating bedside ultrasound may be a primary diagnostic modality for the ICU patient with respiratory failure. So how well does lung ultrasound perform in comparison with what would be a gold standard CT scan? For pleural effusion, lung ultrasound has a sensitivity and specificity of 94 and 97% respectively. For alveolar consolidation, sensitivity of 90% and specificity of 98%. For interstitial syndromes, sensitivity of 100% and specificity of 100%. For complete pneumothorax, sensitivity of 100% and specificity of 96%. And for occult pneumothorax, a sensitivity of 79% and specificity of 100%. As you can see, the examination characteristics of lung ultrasound is in many ways comparable to CT scan. The ratio of air to fluid in the lung are what determine the appearance of lung and pleura on ultrasound. The normal lung contains almost entirely air. A pneumothorax contains entirely air in the pleural space. Interstitial syndrome contains mainly air and minimal lung parenchymal fluid. A pleural effusion contains entirely fluid in the pleural space, and lung consolidations contain more fluid than air and can appear hypoechoic or tissue-like. Here's a schematic of the anatomy of the chest wall and lung. On the left-hand side of the slide, you can see normal anatomy of the chest wall and lung parenchyma, starting with the skin and subcutaneous tissue, the pectoralis muscle, the intercostal muscles and ribs, and then the pleura and lung parenchyma. On the right-hand side of the slide, you can see this contrasted with the appearance of normal anatomy on ultrasound. The superficial structures, the skin, subcutaneous, fat, pectoralis, and intercostal muscles conduct sound waves well. The cortex of the rib reflects sound waves, resulting in a hyperechoic cortex with distal shadowing. When performing lung ultrasonography, there are 6 locations that should be scanned to evaluate the pleura and lung parenchyma. These 6 locations are part of the Blue protocol, which will be discussed further in this presentation. As you can see in the diagram on the right-hand side of the screen and in the pictures on the upper left-hand side of the screen, there are 3 lung zones that are determined for scanning. Zone 1 and Zone 2 are differentiated by the anterior axillary line, and Zone 2 and Zone 3 are differentiated by the posterior axillary line. Each zone has 2 scanning locations, superior and inferior. The transducer is adjusted until a view that includes 2 adjacent ribs, the underlying pleural line, and the predominant artifact pattern, either A lines or B lines, should be obtained. There are a few probes that can be used when evaluating the lung parenchyma and pleura. The curvilinear probe and phased array probe both have frequencies in the 1 to 5 megahertz range. They both achieve good penetration and are good for viewing deeper pathology. The curvilinear probe has a larger footprint, which enables assessment of a larger area of the pleural interface. The ideal probe for exploring the entire pleural surface, including from below the diaphragm, would be the curvilinear probe. The linear transducer has a higher frequency of 3 to 12 megahertz and allows for high resolution but reduced penetration. This is excellent for assessing the chest wall and pleural abnormalities within 4 to 5 centimeters of the transducer face, and ideal for infants and small children. Depending on probe availability, we would recommend starting with the phased array probe or curvilinear probe if available. Here is an example of normal lung sliding, which can be seen in the ultrasound image on the right-hand side of the slide. The visceral and parietal pleura appear as a single hyperechoic pleural line. This line slides from side to side on the ultrasound screen, representing movement of the pleural surfaces during the respiratory cycle. Normal lung parenchyma is not visualized because air scatters and impedes the transmission of sound waves. What is seen instead with normal lung parenchyma is really an artifact called A-lines. A-lines are normal reflection of the pleural line due to reverberation artifact. They occur when sound waves pass through the superficial soft tissues and cross the pleural line, encountering air or tissue that is almost completely composed of air. These waves are reflected strongly by this tissue-air interface and reverberate or bounce back and forth between the transducer and the lung surface. Each volley of sound waves returns to the transducer after a longer period of time and is thus represented as a bright horizontal line equally spaced deeper and deeper on the display screen. What happens when you don't see lung sliding? Well, depending on your patient's clinical history, this may be indicative of a pneumothorax, though there are other pathologies that can cause a lack of lung sliding outside of pneumothorax. Here are two examples of patients with pneumothorax using the linear probe to evaluate the pleural surface. Here you can see a lack of pleural sliding with the presence of A-lines. Sometimes it can be challenging to visualize pleural sliding. One way you can assist yourself is by adding M-mode using the linear probe. When M-mode is applied to the lung exam, as previously discussed, the system displays a representation of tissue motion over time. In the case of normal lung sliding, significant scatter results from lung sliding, and therefore the area on the M-mode tracing deep to the pleural line takes on a granular or sandy appearance, while the relatively immobile superficial tissues appear smooth and linear. This has been termed the seashore sign, as the superficial tissues resemble waves and the deeper tissues the sandy beach, which can be seen as an example in the right-hand side of the slide. When lung sliding has been abolished, the superficial and deep tissues both appear smooth and linear, resulting in the classic barcode sign or stratosphere sign. This again can be seen in the image on the upper right-hand side of the screen. The lack of lung sliding does not always mean a patient has a pneumothorax. There are other causes of a lack of lung sliding to consider. For example, the patient is not ventilating. This may be observed in cases of accidental esophageal intubation or intubation of a mainstem bronchus, as well as in apnea. Lung pulse can also be seen in this scenario, which will be discussed on the next slide. The patient is ventilating, but there is no lung sliding due to a dense lobar consolidation. In these patients, the underlying lung contains significant water, and as a result, there will be a predominant B-line pattern. The presence of B-lines excludes the possibility of a pneumothorax at the interspace in question. The lung sliding may also be difficult to observe due to pleural adhesions, bullae, or pleurodesis, depending on the patient's history. While these patients may have associated B-line pattern, they may have an A-line pattern as well, which is why the absence of lung sliding and B-lines is not sufficient to confirm or rule in the presence of a pneumothorax. To diagnose a pneumothorax, if you encounter a patient in whom there is no lung sliding and the artifact pattern demonstrates A-lines, you should proceed to search for a lung point, which will be discussed later in the presentation. The absence of lung sliding, the absence of B-lines, and the absence of lung pulse with the presence of lung points confirms a pneumothorax. Here is an example of lung pulse, which at first glance may appear like lung sliding, but it appears that the pleura is moving in relation to the heartbeat instead of the respiratory cycle. Here on the right-hand side of the slide, you can see rhythmic movement of the pleura in synchrony with the cardiac rhythm. Its presence indicates that the parietal and visceral pleura oppose one another, and so its presence rules out a pneumothorax. This is often thought as an ultrasound sign of complete atelectasis. However, this may also be seen with dense consolidations. Essentially what is happening is the lung is condensed, leading to transmission of reverberations from cardiac motion to the pleura, and it is not necessarily specific to lung collapse from atelectasis. When evaluating for pneumothorax and comparing ultrasound to chest x-ray, you can see that ultrasound carries much higher sensitivity than chest x-ray, 86 to 98% compared to 28 to 75%, and is reasonably as specific as chest x-ray, 97 to 100% compared to 100%. Previously, we mentioned searching for a lung point when evaluating for pneumothorax. The lung point is the point at which the pneumothorax starts and normal lung ends. To search for a lung point, move the transducer laterally and or caudally, observing for an interspace in which lung sliding is intermittently restored and abolished. This has a sensitivity of 66% and specificity of 100% for pneumothorax in one study of lung point. Here are 3 examples of lung point. Notice how you have a lack of lung sliding, and then intermittently, lung sliding will come in and out of view of the interspace in question. Now we will discuss interstitial syndrome and the evaluation of B-lines. Note these are not identical to the curly B-lines that we look for on chest x-ray when looking for pulmonary edema. B-lines occur when sound waves pass through the superficial soft tissues and cross the pleural line, encountering a mixture of air and water. The mixed density of the lung parenchyma causes reverberation artifact within the lung. This gives rise to discrete laser-like vertical hyperechoic reverberation artifacts that arise from the pleural line and extend all the way to the bottom of the ultrasound screen without fading. These move synchronously with lung sliding. Interstitial syndrome is defined as 3 or more B-lines from one pleural line. B-lines that are roughly 7 millimeters apart, or spaced comet tail artifacts, are artifacts that correspond to thickened interlobular septae on chest CT scan. B-lines that are 3 millimeters or less apart represent contiguous comet tails arising from the pleural line and are artifacts that correspond to ground glass areas on chest CT. You can see still images on the right-hand side of the slide that correspond to B-lines derived from the pleural interface. Here are examples of multiple B-lines seen on ultrasound in real time. On the left-hand side of the screen, you can see a differential diagnosis for diffuse bilateral B-lines that includes both cardiogenic or non-cardiogenic pulmonary edema, diffuse pneumonitis, diffuse interstitial pneumonia, and diffuse parenchymal lung disease. On the right-hand side of the slide, you can see a differential diagnosis for localized B-lines which include pneumonia or localized pneumonitis, localized interstitial lung disease, atelectasis, pulmonary contusion, pulmonary infunction, localized pleural disease, and neoplasia. Here is a still image correlating the presence of B lines to what you may see on CT scan. Lung ultrasound can also be used to evaluate for pneumonia and lung consolidation. Lung consolidations may be caused by a variety of disease processes, including infection, malignancy, atelectasis, contusion, or pulmonary embolism. You may see in a consolidation what's called hepatization of the lung parenchyma. This can be seen in the ultrasound image on the upper left-hand side of the screen, where the right lower lobe has taken on the appearance of the liver. On the right-hand side of the screen, you can see a dynamic air bronchogram. This is a punctiform or linear hyperechoic artifact within the consolidation with centrifugal inspiratory dynamic movement of air bronchograms more than 1 millimeter. In patients with ultrasound visible alveolar consolidation with air bronchograms, the dynamic air bronchogram had a specificity of 94% and positive predictive value of 97% for pneumonia when trying to differentiate pneumonia from atelectasis on ultrasound. The sensitivity was 61% and negative predictive value 43%. Lung ultrasound can also be useful in evaluating pleural effusions at the bedside. Effusions are best visualized in the dependent posterolateral regions between the chest wall and underlying lung tissue. They are typically anechoic collections, though may at times be hypo or isoechoic to the underlying lung, particularly if they are exudative effusions or contain loculations. Lung tissue may appear as a solid organ in cases of moderate or large pleural effusions with associated compressive atelectasis and lung consolidation. You can use the Bollock formula to estimate the amount of volume in the pleural effusion. This is measured with a patient supine, and the transducer is perpendicular to the dorsolateral chest wall. The measurement is taken at maximal inspiration. The measurement is made at the maximal distance between the visceral and parietal pleura. The measured distance in millimeters is multiplied by 20 to give the estimated volume in milliliters. In the images on the right-hand side of the screen, you can see an example of a loculated right pleural effusion with septations. On the bottom right-hand side of the slide, you can see an example of a simple pleural effusion. What's noted by the red arrow is called the spine sign. Normally, the spine is not visible due to the presence of aerated lung. However, when there's pleural fluid, an acoustic window is present, and this allows you to visualize the spine. One algorithm that can be used when evaluating a patient with respiratory failure is the Blue protocol. The scanning locations of the Blue protocol were discussed previously in this presentation. The goal of the Blue protocol is to determine the profile of the lung parenchyma and pleural interspace of your patient. The upper right-hand side of the slide, you can see an A profile is determined by bilateral A lines, a B profile is determined by bilateral B lines, and an AB profile is determined by unilateral A lines and unilateral B lines. In the table below, you can see the accuracy of the Blue protocol in determining various respiratory pathologies when evaluating patients with acute respiratory failure. To briefly review the Blue protocol algorithm, it begins by evaluating for lung sliding. If lung sliding is present and the patient has a B profile, they likely have pulmonary edema, though this does not differentiate between cardiogenic or non-cardiogenic. If the patient has an A profile, then differential diagnoses to consider are pulmonary embolism, pneumonia, or COPD or asthma exacerbation. This can be further delineated by evaluating for the presence of DVTs, or what is not included in this algorithm, but I would advocate for, would be a full cardiac ultrasound as well to evaluate for any signs of right heart strain. If lung siding is abolished and the patient has what's called a B' profile, or B lines in the presence of no lung sliding, then pneumonia may be a likely diagnosis. If the patient has abolished lung sliding and the presence of A lines and a lung point is seen, then the patient has a pneumothorax. If there is no lung point seen, then the patient needs additional diagnostic modalities to further evaluate for the potential pneumothorax or atelectasis. It is important to note that this particular decision tree does not aim at providing the diagnosis, but indicates a way for reaching a almost 91% accuracy when using lung ultrasound. Though this is not used in routine practice, here is an example of using lung ultrasound to predict weaning from a mechanical ventilator. The lung ultrasound score, as can be seen below, assigns points depending on the presence of A lines versus B lines versus lung consolidations. The points are tallied, and the lung ultrasound score at the end of a spontaneous breathing trial can be used to predict the likelihood of successful extubation. And that concludes this presentation.